Now, from the News Channel 5 network, this is Medical Mondays.
Hello, everyone. Glad you are with us. We are talking about something tonight that affects so many people, and that is chronic pain. And we are very happy to have with us someone who can answer your questions about this from the Nashville Pain and Wellness Center, Dr. Madhu Yelameli. Thank you, doctor, for being with us.
Thank you very much. Thanks for having me here. It's a pleasure.
What we want to do is just kind of give people a sense of this topic. It affects so many people. It's a difficult thing for people to get good information about. And that's what we want to do tonight, is just give good, solid information.
Yes.
And so we start with, what is chronic pain? When we talk about that, what is it?
Chronic pain is something, if you go by the definition, it is a pain that exists for more than 3 to 6 months. And any of the treatments that are typically done for such kind of pain have not worked. The pain has continued, and the patient has continued to complain of pain. And now we have done everything that can be curative, and right now we are left with no options. And you just call it a chronic pain and start managing that pain.
3 to 6 months, and this affects so many people. I mean, I know people that have felt like people don't understand them. Mm-hmm. They have this pain, they go to a doctor says, we don't know why you have this pain, and yet it persists. Is that something you see?
That's typically what happens, because when a patient develops pains, let's say you have a back pain, and initially the back pain starts as an event, after an accident or after a fall or lifting something heavy. I'm just taking back pain as an example. This can happen with any other kind of pain. Now, that pain will go away after a few days or a couple of weeks or 3 weeks. The patient goes to the primary medical doctor, gets some treatment, or goes to a chiropractor, gets some manipulations done, or goes to the surgeon, has a surgery done, depending on the severity of the case. And then the pain goes away, but it can return later on when a similar event happens, when suddenly a patient has a trauma or gets rear-ended in the traffic or something. So the pain comes back. Now, over a period of time, chronic pain can develop in such patients too. Those who have acute episodes over a period of years, sometimes these episodes become more frequent and more severe. So this also can be called chronic pain, whereas this doesn't really fit into the definition of 3 to 6 months. This is over a period of years. The patient would have developed this pain. Some patients I have seen who have had 5 to 6 surgeries on their back, and each one would have helped the patient's pain for, let's say, 2 years, 3 years, 5 years. And then finally there comes a day when nothing is helping. The patient is still in pain. So this is also another kind of chronic pain which really does not fit into that definition of 3 to 6 months pain.
When we talk about pain management, how do you define that? Because there's all kinds of definitions swirling and thoughts that people have when they hear the term pain management. What is your definition?
Pain management, for me, pain management is trying to figure out what is causing pain is the first thing that matters most. Many times when we as pain physicians, we are trained to identify the different causes of pain, which a regular doctor may not be trained to do that. There are certain structures in the body that can cause pain that we are aware of. So we put these patients through a set of a thorough examination first, a physical examination. We touch the body where the pain is, and we run them through some investigations like scans and nerve condition studies and other investigations. And we try to come to a diagnosis first. We come to a possible, okay, this is the structure that is causing the pain. Then when we tell the patients, this is really amazing. When we tell the patients, look, I think this is where your pain is coming from, they feel so good that finally somebody could find the cause. Half their pain is already gone, because most of this time they were in the dark about what is going on here. I have so much pain, I go to the doctors, they say nothing is wrong. But as pain specialists, we are trained to do this. We can figure out, is it a neuropathy? Is it coming from a facet joint in the back? There are little joints in the spine called facet joints. Now these can get arthritic. And that can cause severe back pain, which a surgery might not have taken care of. A surgery won't take care of your arthritis in the back. There are so many other structures in the back. There is something called sacroiliac joint in the back. Now, that doesn't even show up any abnormalities on the MRI scan if you do an MRI. So we know how to subject the patient to tests that will tell us probably possible causes of pain.
Which is such an important part of the battle. Because if you know what is actually the cause of the pain, you can then begin to actually cure it. Treat it in a way. Treat it in a way that does more than mask it.
Correct.
Because that's the other thing that you hear happen a lot. That
correct.
Someone is in pain,
right.
and they go to a place and it's simply mask. And the root cause is never treated.
Never treated. So once we know where the pain is coming from, we start managing it. We may do certain tests, we may do certain injections, procedures, and we may subject them to more tests before figuring out where the pain is. So once it is figured out, we start treating them with different kinds of medications. There is a whole range of pain medications. Each pain medication works on a particular type of pain. There are non-steroidal anti-inflammatory drugs, which we know about, ibuprofen, naproxen. These drugs help with arthritic pain. There are neuropathic drugs like gabapentin or pregabalin. There are drugs which help certain other central pain syndromes like duloxetine. So, and there are muscle relaxants, and there are local anesthetics. So all these drugs, we may be using any of this or a combination of these drugs along with certain procedures to help manage this pain based on what the cause is. So chronic pain is quite prevalent in the world. Actually, recently there were some big studies that were done encompassing like several countries across the world. And they found that even conservatively, they have put the figure at 20 to 30% as the prevalence of chronic pain. So 20 to 30% of the population suffers from chronic pain. And there have been many studies in US too, done by very reliable organizations that have shown that there's a big prevalence of pain. That is why we're setting out there to manage this problem. And of course, there still needs to be a lot of awareness that has to be built among the physicians and the public in general about this problem.
When you say awareness, what do you mean by that? You say even awareness among physicians.
Yes.
What do you mean?
We see all the time patients coming to us with chronic pain, but the physicians who have treated them prior to that may not have figured out where the pain is coming from. So many times, let us say you have a disc herniation and you go to the surgeon and you have back pain. So the disc is taken out and the bones are fused. Now, if you go back to the surgeon after a couple of years, I still have pain. Now you take an X-ray and everything looks good. The disc is not there. There is no problem as far as the X-ray goes, or an MRI, repeat MRI goes, but still you're complaining of pain. So why is it so? The surgeon may not be able to figure out that, or a general physician, or let's say a specialist who has nothing to do with pain management, let's say an endocrinologist or some other specialist may not know exactly what the cause of this pain be. That doesn't mean that the patient does not have pain, or that doesn't mean that there are no specialists who can figure this out. What I want to say using this forum is that we are here. We will try our best as pain physicians to figure out why the patient is complaining of pain. Because we see pain patients suffering severe pain, just giving up on life. If the doctor says that I don't know where your pain is coming from, then the family and friends start doubting the pain, and they're asked to work. They're asked to continue to function in the family. They have to take care of the kids. They have to do the chores at home, or if they're working outside, they have to continue to work. The employer may not believe in your pain. The co-workers may not believe in your pain. So it becomes a big problem for the patient who has a genuine pain to function in the society. So it's extremely important that we tell the public, the physician, the medical faculty, the medical fraternity, and the public in general that yes, there are ways to figure out why there is pain, and there are people who are trained to do this. And
that is one more thing before you go to break. I mean, the other thing that people sometimes focus on is the whole aspect of addiction that is associated with pain management. What do you want people to know about that?
I feel in the field of chronic pain management, addiction has become a distraction. So the opioid addiction is just taking away all the attention from chronic pain management, which should be actually all this attention should be actually bestowed upon the pain patients who are suffering, and not about addiction. And to discuss why this has happened, that probably will take several hours to discuss this in this forum. I mean, it's a very, very big problem. I totally understand that it's become a big social issue, and but I think right now things are being done, regulations are being put in place to control this epidemic of opioid abuse and addiction. And I do agree that pain management is partly responsible, or maybe to a great extent responsible for all this.
And it can be treated without that, obviously.
Yes.
All right, so we have to take a break. We have several
Sure.
calls. If you want to call, there's the number, 737 plus 737 7587. We will take a break and take your calls. We'll be back right after this.
Seven, 6, 5, 4, 3, 2.
Welcome back to Medical Monday, talking with Dr. Madhu Yelameli with the Nashville Pain and Wellness Center about chronic pain, something that affects so many people. We already have several calls, so let's go to the phones. Let's go to Jerry on line 1. Hello, Jerry.
Yes.
Hi, what's on your mind?
Yeah. 2012, I had a total knee replacement.
Okay.
okay.
And even before that, my knee was hurting on the outside of my knee, but it wasn't like in the joint mostly. But it's
Okay.
every day since then, I hadn't been able to get up and get around on it good. When I sit down, it hurts, and when I walk on it, hurts. It's on rough terrain and stuff. And I also do construction work.
Oh.
How old are you?
61.
61. Okay.
And still working with this pain?
Yes.
Oh, that's very really commendable. I mean, see, this is a very good question you have asked, Jerry. Chronic pain. This is a good definition of chronic pain. You have had surgery. You had knee problems. You had probably end-stage osteoarthritis of the knee. So that's why you underwent knee replacement, isn't it?
He may not still be there. But is that, I probably,
Okay.
let's say
So,
it is.
so a lot of patients continue to have pain after such a surgery. It is not that the surgery has not helped. Surgery would have helped the patient with the pain, with the problem in the knee. The person would be now able to walk, but there is still pain. That doesn't mean in any way that the surgery was not needed or the surgery was not successful. The surgery has done its part. There's a major part of the problem here is that probably he was not even able to walk before the surgery was done. Probably the knee was swelling up all the time, but now he's able to walk, he's able to take care of most of the stuff, but the pain is still there. So now we come into the picture to try to manage this pain. Now try to find out what the problem is. Why is there pain? Once there is just metal in the knee, there is nothing else. So we should remember that there are other tissues around the knee joint. There are muscles, there are tendons, there are ligaments. All these can cause pain. Many times when you have a surgery, the small nerve endings in the tissues around the joint get damaged and it causes neuropathy. I have seen patients who have compressed nerves, pinched nerves in the back at certain levels that can refer to the knee. In fact, the pain may be coming from the back too. So we always look at a patient who continues to complain of knee pain after knee replacement. We always look at the back. We take an MRI of the back and see is something going wrong there? Is that causing the pain in the knee? And many times we have found that there is a compressed nerve in the back that is also causing part of the problem. So we try to address that. We try to address the compressed nerve in the back. Or we try to find the cause of pain around the knee joint itself. And nowadays we have also started blocking the nerves that supply the knee joint. And see, these nerves had a big role to play when there was a real knee joint before. Now the knee joint is gone. There is only metal. We don't need all these nerves going into the joint just firing up all the time. So sometimes we block these nerves. This is something new. It's not done on a regular basis, but of late pain physicians have found very good results by just ablating the little nerves that supply the knee joint, that used to supply the knee joint in the
And
past.
how do you do that? So how do you stop those nerves or deal with those nerves? How is that done?
So first we do just block it with local anesthetic and a little bit of steroid if needed. We just block these nerves and see if that takes the pain away. It's diagnostic. The pain relief may not last a long time. It may just last a few hours, maybe a couple of days, or maybe a week at the maximum. But if it does go away, if the pain does get better when we block these nerves, that's a good indication that these nerves are causing the problem. Or the tissues around the knees, around the knee joint, the tissues are causing the pain. So when we block these nerves, the pain goes away. Then what we do is we use radio frequency waves, which actually raise the temperature around the nerve from anywhere from 42 degrees to 80 degrees, depending upon what we choose. And we just ablate these nerves. These nerves are not doing anything except feel the pain in the knee. So when we ablate these nerves, patients get prolonged relief for several months to a year, and it takes just a few minutes to repeat it whenever the pain comes back. So there are several ways we can manage this pain. So this is just a good example of how pain management can get into the mix and try to help these patients.
And this is not surgery, right?
No, this is all done. Most of these procedures that we do are done in the office, or in the hospital or a surgery center. And they're all vast majority of them are same day procedures. Like they just come to the clinic and get it done and go home within minutes, with maybe after 30 minutes of, if they get sedation, IV sedation. We just watch them for 15 to 20 minutes, and then once they feel better, we just send them home. So
somebody like Jerry, and I bet that's a fairly common one, knee pain. Mm-hmm. The first thing, so if somebody like that comes in and says, I had surgery and I still have pain, what's the first thing you generally do? Is it the MRI, or kind of what's the first thing you would do?
First thing I would do is, as I said, first thing is examination.
Right.
Examination. That's very, very important in pain management. We don't rely on imaging studies as much as we rely on examination. So once we know the examination findings, then we try to correlate them with the imaging studies and with other tests. I may get a nerve condition test done for him to see if there is a neuropathy around the knee, or I may get a nerve condition study to see if there is a pinched nerve in the back. or I might do an MRI of the MRI of the spine. Depends on what I see during the physical examination. If I feel during the physical examination that all the pain is coming from the tissues around the knee joint itself, I may just start treating him with topical ointments or topical creams, or I can just start him on some pain medications initially while we are trying to find out what is going on, and then come up with some procedures that can help him in the longer run.
Jerry, thank you. Thank you for that call. Thank you for sharing that. Let's go to Donnie on line 2. Hello, Donnie.
Good evening.
Hi, what's on your mind?
I got a couple questions. I've had my spine 35 years ago got messed up, and I've had pain since then. I've had medicine for it and tried the injections. None of it works. I got a machine at a chiropractor thing in Nashville somewhere, but it cost $6,000 almost to take care of it, straighten it out. But I had a bad fall about 2 months ago, and I bruised my brain, they said. Is there anything he can do about that? And I'll hang up and listen.
Wow. All right. Thank you, Donnie, for sharing that. I'm sorry you're going through that.
Oh, I'm sorry too. Sorry you had to spend all that money and now the pain is back. He said he smashed his something. I didn't get that long.
It's his back. It's
Okay.
back pain.
No, the back pain. So again, this is the kind of situation where the pain needs to be managed. So he has had medications, he has had injections. So we may have to again go back to the drawing board and see, go to the imaging studies, examine him again. So this we have to do on a continuing basis. In a patient like him, who has had 35 years of pain and has had back surgeries, who has already tried everything, this becomes more complicated. So we have to talk to these patients, see these patients more often, patients like him. Every time something happens, an event happens where the pain gets exacerbated, we call it acute flare-ups of the chronic pain, then we have to be there to figure out what happened now. Where is the pain coming from now? It was okay, it was earlier, probably it was coming from somewhere else, now it may be some other place the pain is coming from. So every time we do a targeted injection, it depends on the physical examination. So it is not that he had pain once and we all decided that it's coming from a so-and-so structure and we keep targeting the same structure again and again and again every time the pain comes back. No, we have to have an open mind. We have to look again, we have to just start all over again and see where the pain is coming from and try to help.
He mentioned a treatment. He said $6,000. Is that uncommon? And money is such a big issue.
Yes.
For so many people, obviously. Let's broach that subject. I mean, are you aware of the treatment he's talking about? Is that uncommon to spend that kind of money?
No, it is very common. I mean, we know there is, I think what he's talking about is a lumbar traction. It's a very complicated instrument. It's an apparatus. It's typically used by chiropractors, and that's what he said. I think he went to chiropractor.
Right.
So they use this machine to put traction on the spine and try to get the disc to go back into place or something like that. So it is very it takes several sessions. I think they go for these sessions several times a week, then several times less and less frequently over a period of several months. I think I'm not very clear about how. I mean, it all depends on each chiropractor how they manage this. So it's not something we do. So I shouldn't be talking too much about it. But yes, I have seen patients who do feel better after this. But again, this is a one-time treatment for $6,000, and then if the pain comes back, again having that done, it's going to be very difficult.
It's not an ongoing management.
Right.
All right, we have to take a break. We have several calls. If you want to call, there's the number, 737 plus 737-7587. We'll take a break. Be back right after this. Welcome back to Medical Monday. We were talking about chronic pain with Dr. Madhu Yelameli, Nashville Pain and Wellness Center in Brentwood. Several calls. So let's go back to the phones.
Sure.
Let's go to Maryland on line 3. Hello, Maryland.
Yes.
Hi.
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 How are you doing?
Good.
What's on your mind?
Well, I have a couple of chronic pain issues.
Uh-huh.
The first one is interstitial cystitis of the bladder, and I didn't know what the doctor might have to say about that, what to do for the pain.
Sure.
All right, well, yeah, we'll take that one and then we'll come back to you. Okay.
It's a very common problem. We see this a lot. Interstitial cystitis causing pelvic pain. Pelvic pain itself is a big problem among women. And one of the major reasons for pelvic pain is endometriosis, which is a common condition. And the other major problem, most common cause of pelvic pain, the second one is, I think, interstitial cystitis, which is where the bladder, the urinary bladder gets inflamed and it becomes chronic. And they first go to the gynecologist, they look up, whatever they can do, they will do. And typically they are next seen by urologists and who diagnose them with interstitial cystitis. There are certain things the urologists do to help patients with interstitial cystitis. But if she's asking a question on this forum, then probably she has already tried all that.
Right.
Now they are typically referred to us for chronic pain management. And we try to help them with the help of medications first, pain management, pain medications. And there are certain procedures that we do for pelvic pain. So there is something called a plexus, a bunch of nerves that sits right in front of the spinal cord, in front of the vertebral column, not the spinal cord, the vertebral column, the bone, in front of the spine. Inside the pelvis. There's a bunch of nerves. It's called superior hypogastric plexus. This plexus of nerves actually supplies nerves to all the pelvic organs, including the urinary bladder. So we try to block this plexus under fluoroscopy guidance, under X-ray guidance. We place needles in front of the spine and we block this. And we have seen good results from this. Typically, the pain relief lasts, about a month, 2 months, 3 months, and the pain is brought down to a level where pain medications help well. And then, when the pain comes back, we just have to repeat these blocks. Sometimes we also do what I earlier described as radio frequency ablation. We can do the ablation of these nerves and give more prolonged relief in the bladder. We sometimes inject alcohol or phenol to ablate these nerves. Not only radio frequency, we can use the other phenol and alcohol too to ablate these nerves and give prolonged relief from pain. Also, those who have not responded to these procedures, we have done spinal cord stimulators. I have done myself implanted spinal cord stimulators on several of my patients with interstitial cystitis with pelvic pain, and they have done really well. In fact, it's surprising that it's done pretty commonly nowadays. Spinal cord stimulators for back pain and leg pains and for neuropathy, but for pelvic pain it really works very well.
So we've had 3 calls already, and we've heard of knee pain, back pain,
yes,
and now pelvic pain. Those
right.
Are those the most common? Or
The
what
back
are some
pain
of the
is the most common.
The back pain is
Low
definitely.
back pain is the most common. Then we come to neck pain. That's pretty common too. Knee pain is, of course, extremely common. But most of the knee pains are taken care of by orthopedic surgeons. They do their injections, then they take them through surgeries, then end up with replacement. And most of the surgeries help very well, and patients with knee pain do not end up with us unless there is a problem like this. In spite of surgeries, if they continue to have pain, that's when they come to us.
And now, Marilyn, you said you had another question. Do you have another question, Marilyn?
Yes, I have severe arthritis in my ankles and feet, and I have some other problems with my feet too.
Uh-huh.
And the only way that I can be where I can walk is to get cortisone cortisone shots. And I have bone spurs, spur heel. I have Achilles tendons that are torn. And
Have you already seen
there's
orthopedic
something
surgeons?
to do about that.
Have you already seen an orthopedic surgeon for all these problems?
No.
I think if you have arthritis of the ankle joints, you should first try to see an orthopedic specialist who specializes in feet problems, and they will have some options for you. First, you have to take care of that arthritis, whatever bone spurs you have. It may be plantar fasciitis. You may have bone spurs at the bottom of the foot, which can also cause pain when you're walking. It may not be just arthritis in the ankle joint. You can have arthritis even in the smaller joints in the foot. So they will be able to help you most of the time. If there is not much a surgeon can do, and if you continue to have pain, then pain management will be your next step, and we can certainly help. We can always do certain tests and see if there is any neuropathy, if what else can be causing the pain. Is it just arthritis causing the pain, or is there an overlying neuropathy in your feet? Is it possible that some of this pain is coming from the back? I mean, we can look at other causes for feet pain and try to figure out try to stop the pain from one cause, at least the most severe of those causes, and then that should give you good relief. So I think first step for you is to go to an orthopedic surgeon.
And are you generally the first place people go, or they go to you after someone else?
I always recommend that they come to pain management after trying all the curative treatments out there. There are plenty of extremely advanced procedures and surgeries and methods of curing these problems that are available. I mean, not exactly arthritis in the ankle joints, I'm talking about in general. So they should go to, let's say we talked about going to a urologist, going to a gynecologist for pelvic pain, going to an orthopedic surgeon for a joint pain, or for back pain and neck pain, you go to a neurologist or a neurosurgeon first. And if they, many times, majority of the times, if the problem in the spine is severe enough and a neurosurgeon does a surgery, or an orthopedic or a spine surgeon does a surgery, the pain gets better. And the patients, I've seen lots of patients who just had surgery and they're doing fine. I mean, we see only patients who have not done fine. That doesn't mean that there are I think majority of these surgeries help only when they stop helping. Or if the surgeon says, look, there is nothing more I can do, that is when it's good that is when the patient should come to pain management.
To actually manage the pain.
Correct.
There was the chance, hopefully, to cure it.
Correct.
And I know that's a loaded term, but if that's not going to happen, then it can be managed.
Yes. Or if they have already done whatever they can. Let's say for this lady who just called, has ankle pain, and she's been told, look, there is nothing much we can do. There is no surgery available, or they can give an option. Let's say there is an end stage osteoarthritis of the ankle joints, and the surgeon may say, look, all we can do is fuse you up, and then you won't be having any movement in the ankle. Then the patient may not want to have that done. So at that time also, so this is another scenario is when a surgeon offers, or another specialist, not necessarily a surgeon, another specialist offers a procedure or a surgery, and the patient is not willing to have for whatever reason. That is another reason scenario when they can come and seek treatment by a pain specialist.
Let's go to James. Hello, James.
Oh, this is James.
Hi, James. What's on your mind?
Neuropathy.
Neuropathy?
I had to have a leg took off. I mean, foot.
Oh my God.
Down below my ankle. I mean, my knee. And I can't even wear one of them prosthetic feet. And,
so you have neuropathy, and they have done amputation. Is that what you're saying?
That's what I'm saying. Yes, sir. And I cannot. I know you use a walker all the time to get around. I've had neuropathy a while.
Mm-hmm.
I run into my concrete porch out here, and I broke this leg. And it finally just got. I thought I'd doctor it myself a little, but Lord, it got worse, and then it sure enough got bad, so they decided to take it off.
So one of your legs has been amputated below the knee, and you are wearing a prosthesis.
Yes, sir, below the knee.
And you still have neuropathy on the other side.
Well, I've got it over on that side too. But
Okay.
I'm still walking on one foot. But come night, all you do to get to the bed.
Oh, I'm so sorry, James. What can be done there?
Yeah, neuropathy is a big problem too, and the most common cause for neuropathy is diabetes. I mean, he may be a diabetic person, or neuropathy can happen from other causes too. Patients who have had chemotherapy for cancer treatment in the past would have developed neuropathy. So some of these neuropathy is one of the toughest pain to treat, to
And
manage.
what is neuropathy? What does that mean?
Neuropathy means damage to nerves.
Okay.
Let's make it, simply put, when the nerves are damaged, like the small nerves are damaged, not the main trunk, the little nerves are in the feet, or in the hands, or anywhere in the body, if they get damaged, we call it neuropathy. So not all neuropathies need to be painful. So a patient can have numbness in the legs or the feet from diabetes and may not have any pain. But there are vast majority of patients who have neuropathy do suffer from pain. And that's a very extreme step that they had to take to amputate his leg because of neuropathy. I'm sure there was good indication for that. And when we do amputation on a patient like this, there is a possibility that he can develop phantom pain. So he continues to feel the pain in the foot, which is not there. So he may be feeling that. So this is another extreme case of chronic pain management, where we will have to treat him with multiple modalities. I may not be able to do one thing and take away his pain. I may have to do several things, give him some medications, do some procedures, and bring his pain down to a level where he can function, where he may be able to take care of some of his activities of daily living. Now that's where our goal will be. We have to set our goals. And the goal in his case would be to just make it possible for him to, take care of his activities so that he's not dependent on somebody. And I try to be as active as possible, which is very important for neuropathy. Neuropathy patients, we try to keep them as active as possible.
Right.
Otherwise it gets only worse.
Well, we've had some great calls. If you're on the line, hold on. We will get to you. We're going to have to take a break. Be back right after this. Yes. Well, we'll talk maybe.
6, 5, 4, 3, 2.
Welcome back to Medical Monday. We're talking about chronic pain. Dr. Madhu Yelameli is with us from the Nashville Pain and Wellness Center in Brentwood. A lot of calls, so let's go back to the phones. Joy. Hello, Joy.
Yes.
Hi, what's on your mind?
Yes, I have a question for the doctor. Actually, I have a couple. I have fell and broke my tailbone 3 times in my life. I'm 41 years old. I have been going to pain management since about 2008. Excuse me. I was just wanting to know, as far as the weakness in my legs from the nerve damage, does that ever tend to get better, or does it just continue to get worse? Is there anything they can do for that?
So exactly where was the fracture again?
It was in it goes from my L3, L4, L5, S1.
Uh-huh.
And I have facet joint arthritis.
Uh-huh.
And the nerve damage from the pinched nerves I've got weakness in both my legs because I have nerve damage that goes down both my legs.
Have you had any surgeries on your back?
I have had a laminectomy, and they want to do a lumbar fusion.
Fusion, okay. And they have found that you have weakness in the legs and your nerves are damaged.
Yes.
Okay.
So what do you think of that? She's 41.
She's 41, yeah. She's very young, and
she's very young,
she has a severe problem with, I think it looks like that the nerves are damaged. So again, she has already had laminectomy, and she still continues to have pain down the legs. So the lumbar fusion is typically done to stabilize the spine. And she's already getting pain management too. So this is again another extreme case where we had to again look at all the possibilities here. She says that she has facet joint problems. She probably also has an SI joint problem. It's possible that the laminectomy has been done at a particular level, but the level above and below are still not addressed. It is possible that once the nerve is damaged, like we were talking earlier about neuropathy, this we call radiculopathy, which is again a type of neuropathy where the nerve is damaged. So we had to treat a damaged nerve, and neuropathic pain is different from a musculoskeletal pain. So we have different drugs for that. I'm sure she's already going to a pain specialist, and he would have already treated her for neuropathic pain. We have to see where else the pain may be coming from. Try to do some targeted injections. If all the injections have been done and everything has been exhausted, we can again look at, talk to the surgeons, and surgeons have already offered her some surgeries. We can look at that and see if she can continue to have that surgery too, and get the spine stabilized at least, and then we can only focus on the neuropathic pain, and whatever pain is left after the surgery we can focus on that. So in a complicated patient like this who has already had extensive pain management, surgical management and everything, we have some certain procedures that we do, like a spinal cord stimulator that we talked about earlier. This actually helps with neuropathic pain. This is an implant. We implant it in the spine and try to stimulate the spinal cord with these electrical leads, and it's a pacemaker for the spine, and there is a battery that goes under the skin which keeps these vibrations going. So the patient feels only the vibrations, and the pain is not felt. So it's a complicated medical phenomenon that I can explain. It's called a gate control theory, but I don't want to go into the technicalities here. But a spinal cord stimulator may be a good option for her. I'm sure the surgeons would have already discussed this with her. Even the neurosurgeons, spine surgeons do that kind of implant surgery. But we have seen patients, I have patients who have already had surgeries, several surgeries, have also had the spinal cord stimulator implants, which helped for a few years, and they have been taken out because it stopped helping. So these are patients in whom we have to finally end up just depending on medications. So this is when we may have to use really potent medications, which are called opioids, which everybody is aware of, narcotics in other words. These are extremely potent drugs which we may have to treat her with. Probably she's already on those drugs by now.
And when you're 41, you want to avoid that, right? I mean,
so
you really
the final step for a patient like this is, if she's already getting a high dose of narcotics, then this becomes a very specialized narcotic management, the opioid management. And then we have certain implants that we do, wherein we have, it's called a pump. It's a spinal pump, wherein we can implant a spinal pump under the skin and fill it up with morphine, and it gets pumped directly into the spine. So you don't have to take it by mouth. It goes directly into the spine and helps the pain. And the amount of drug that enters the body through a pump can be 100 times less than what you take by mouth and still give better relief.
That's good. So
these are some of the options that we have for a patient like that. But again, I'm not saying that Joe, right, is a candidate for a pump right away. There may be several things that have not been tried. Again, among pain physicians also, there is a wide range of capabilities. I don't know what kind of pain management specialist she's seeing. Whether there are pain specialists who only do medical management, there are pain specialists who will not do medical management, will only do procedures. And so we may need to get evaluate and see what she has already done, what she has not tried, and try the simple things first, and then take her through the
fascinating. There's a lot there. Joy, thank you for sharing that. Let's go to Tony. Hello, Tony.
Yes.
Hi, what's on your mind?
Your prior caller answered a bunch of my questions. I'm 56 years old, fixing to be 57, and I have more or less the same kind of condition. Mm-hmm. I'm taking meloxicam right now and gabapentin, and it is tearing up my stomach. I can no longer take it no more. I want to get off of it. I don't believe in pills for a solution. My main question is, because of my age, what can I expect on my nerves regenerating themselves?
So you have back pain and you have had surgeries?
Yes, I had a herniated disc, and it cut into my nerves, and my left leg don't react the way it used to no more, and I'm kind of lost.
I think there is a lot we can do for a patient like you. I mean, it looks like you haven't seen a pain specialist yet. You're taking quite basic pain medications like non-steroidal anti-inflammatory drugs like you said meloxicam, which can cause problems if you take it on a regular basis on a long-term, over a long period of time for several years. So there are certain things we can do. Again, compared to the previous person who called, yours looks much simpler actually. There is plenty we can do for a patient like you. So I urge you to see a pain specialist and see what are the options available. Again, we have to put you through a thorough physical examination first and see exactly what is causing the pain in your back and down the legs, and see what can be done. Many times we refer patients back to the surgeon. If we see that after our evaluation, we see that, you know what, you are a better candidate for surgery than for just injection procedures or just getting on some medications. How come you haven't tried this? Let us go and talk to your surgeon and get their opinion. And who knows, just as surgery can help you for a long period of time. So there is a lot that we can do.
All right, we only have about 2 minutes left. What do you want people to take away from the discussion tonight? 2 minutes in this segment. What do you hope people have a better understanding of after this?
So what I want to tell the public and the medical fraternity, using this as a good forum for that, is that chronic pain is a real thing. And we have lots and lots of patients who don't want any medications, like Tony, who just called, who doesn't want to be on any medications but wants some help. There are people who are doing 2 or 3 jobs with severely degenerated spines and joints, trying to take care of their families, and they just want somebody to help them. It is not all about getting opioids or addiction, which is a big distraction, as we discussed earlier, to the real chronic pain management. So I feel that chronic pain management is an upcoming field. And we need to recognize these patients who really need help and try to get them help.
There's certainly demand for it when you hear all the calls. All right, we're going to take a break. When we come back, we will give out your information one more time. We'll take a break.
Thank you.
Come back right after this.
Seven, 6, 5, 4, 3, 2.
So in our final minute, we want to give you some more information about how you can get a hold of Dr. Yelameli, and there it is. And what would you recommend? Phone number, all of it?
Yeah, all of it. And there is a lot more information we have put in on our website. It's NashvillePainCenters.com, as if we have several centers. But there is only one center. It's in Brentwood. And there is a lot of information available there as to what we are capable of doing and how we treat our patients, and some tour of the practice. So I request your viewers to go to the website and get more information.
The website, very good information there. Thank you for your time.
Thank you very much.
Good information. Thanks for your calls. Stay tuned. Titans Talk is coming up next. Have a great night, everybody. There's like a wide shot or something. Yeah.
Oh, okay.
But now you're done. Good job.
He's ready to go.
I thought you were telling me, get up.
There's going to be another show on here in a few minutes, so we do leave pretty fast. Well, you did great. That was great. Thank you.
Awesome job.
Thank you very much for the moral support.
Oh no, it was really good, and we watched on the screen, so we'll
it looked
we'll
great
have
in there.
the
You
DVD
could
for
hear
you.
yourself in there.
Well, thank you, sir. Thanks.
Because it's much different when we're sitting here.
From the News Channel 5 Network.
Aaron than watching on the screen. We went back there. Yeah, because we could hear you really well in there. Because you're talking to the mic. We could.
Oh, yeah, you
Mic.
could, yeah.
Yeah.
Right, yeah.
Because we were having a hard time hearing it in there. Thank you. Thank you. Oh, stay. Hey, Tom. Yes, so we'll go back to the second. Yeah. And so, and you're developed, DVD, and then you and Sarah and I'll draw, probably I'll bring it on. One of us. Nope. Bring it on. I'll just, we all the DVD that you put on. Okay, yeah. Usually like when they do a shout out, we have it the next day when Mary Ellen does her. And then, I'll get you an encore. Will you share on schedule? Watch it yourself. Oh, just you record it. Well, here, let me walk you out. She's gonna walk you out and then let me know if
Alright, we got 20 seconds.
Yep.
But he hasn't opened first, so.
Hey, Andrew.
From the News Channel 5 Network, this is Titans Talk.
Hey there, and welcome in to Titans Talk. A frustrating day yesterday for the Tennessee Titans. And let's take a look at some of the highlights from that game yesterday as the Titans go into Washington. Kendall Wright gets them on the board and in front early on with a touchdown catch. But here's really where it all went wrong. Colt McCoy comes in and becomes an immediate Redskins folk hero. Pierre Garçon making the defense look silly. 70-yard touchdown pass on McCoy's first pass in 2 years. But look at that. Charlie Whitehurst to Derek Hagan. 38-yard touchdown. That put the Titans in front briefly, but McCoy in Washington marches down the field. Kai Forbath with a 22-yard field goal to win it for the Redskins. Hail to the Redskins for just the second time in 15 games. 19-17 the final. Washington wins. And the Titans once again find a way to lose a game that was there to win. A lot of frustrated guys in that locker room after the game. A lot of frustrated guys today over at St. Thomas Sports Bar. Guys that didn't want to talk, frankly, because here they are, 3 weeks in a row, with the lead in the fourth quarter, opportunity to win a football game, and everything goes wrong, essentially. You have the offense with an opportunity to run out the clock. They were unable to do that. Huge penalty on Brian Schwenke. Perhaps a penalty that could be debated, but a huge penalty nonetheless. Backs them up. The defense then has to go on the field after some conservative play calls and a punt. You've got 80 yards of grass behind you to defend, and they're unable to do it. Just like they did against Cleveland to give up the late touchdown yesterday, the long drive that they are able to come down the field and get that game-winning field goal. A very, very disappointing day for the Titans. And, frankly, statistically, defensively, they played a pretty good game, but there are some big plays that cost them in a big way. Niles Paul had that 50-yard catch you saw a moment ago. Pierre Garçon with the